1, 2,
and review, somebody email.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Usually when we talk about a medical diagnosis or a treatment plan, there's this underlying expectation of precision.
Right. It feels like engineering.
Exactly. It's engineering. Like if you break your arm, you go to the hospital, they do an x-ray, and the doctor just points at that jagged white line on the screen and says, there it is, that's the problem.
It's highly binary. We're totally conditioned to expect healthcare to just be a matter of identifying a physical break or a rogue cell and then deploying a physical countermeasure.
Right. Broken or not broken. It's clean. You put a cast on it, you take a pill, you do surgery. The problem is isolated, and the intervention is super tangible. We like things to be visible.
We do. But the moment you step into the world of psychiatric care, mental health, neurodevelopment, that x-ray machine is utterly useless. The entire paradigm of what an intervention actually is just completely shifts.
Yeah, because you can't just cast a mood disorder.
Exactly. We're looking at a clinical landscape where the primary tool isn't necessarily a scalpel or a bandage or even a pill. The intervention is a relationship.
And that's what we're getting into today. Psychiatric professionals use this hidden psychological architecture to heal people, and we are basically stealing their blueprints. We're doing a deep dive into the true structure of human connection in a clinical setting.
And for anyone listening who is, say, a nursing student or preparing for their boards, this is vital. My goal today is to give you that 80-20 breakdown, the 20% of the concepts that will give you 80% of the understanding for exams, clinical judgment, and most importantly, safe patient care.
Because we usually think of medicine as just chemicals and an IV pump, right? But here, empathy, trust, boundaries, they're dosed out with extreme precision.
They really are. It's a masterclass in human psychology. Whether you're working in healthcare or you're just fascinated by how humans tick, understanding this framework fundamentally changes how you view interaction. We're going to unpack how professionals use their own personalities as literal medical interventions.
And what's wild is that the absolute highest yield concept here, like the foundational thing you have to know, starts by dismantling a really persistent myth.
Oh, the nice person myth.
Yes. The assumption that a therapeutic relationship is just about being a friendly person.
Which is the default assumption for most of the public, right? We think of psychiatric nurses or therapists as these naturally angelic, endlessly caring people who just radiate warmth, and we assume that warmth somehow magically heals the patient.
But clinical effectiveness isn't just about being friendly.
Not at all. Being friendly is a social construct. It is not a medical framework. If you're looking at NCLEX-style questions or real clinical priorities, you need actionable components, and the bedrock of that entire structure is trust.
But let's look at trust, not as this abstract, warm, fuzzy feeling. In this clinical framework, trust is a measurable behavior.
Right. It requires a concept known as congruence.
Congruence. Think of it as like writing code for a software program.
Yeah.
If the syntax isn't exactly right, the whole program crashes. In human interaction, congruence means that your words and your actions match exactly, without exception.
It requires absolute precision. Like, if a psychiatric professional tells a highly anxious patient, I have to leave the floor for a clinical conference, but I will return to check on you at exactly 2 p.m., that isn't just a casual workplace promise.
It's an intervention.
Exactly. It's a clinical intervention designed to build a predictable environment. If that provider walks in at 2:15 p.m., or if they just, peek their head in from the hallway and say, sorry, things are crazy, I'll catch you later, the code crashes.
The intervention fails completely.
Completely, because you have to put yourself in the shoes of a client in a vulnerable state. Let's say they're dealing with severe paranoia or profound generalized anxiety. To them, the world already feels chaotic and unsafe.
So the provider has to act as like a fixed point of gravity.
Right. If you make a verbal commitment and don't follow through to the minute, the patient's confirmation bias just kicks in. They think, see, people always lie. The world is unsafe. I am not a priority.
Trust doesn't just slowly chip away. It evaporates instantly.
And congruence goes way beyond timekeeping. It's deeply physical. It's about ensuring that your nonverbal communication, your body language, eye contact, posture, perfectly mirrors your verbal communication.
There's a classic scenario for this, right? The angry client in the hallway.
Oh, yeah. Imagine a deeply agitated, angry client confronting a nurse. The client yells, "You don't even like me. You're just pretending."
High tension. And the nurse, trying to de-escalate, says, "Of course I like you. I am here to help you."
But while saying those polite words, the nurse is physically backing away, crossing their arms, and darting their eyes around looking for an exit.
That is incongruence in action.
Totally. The verbal component, the reassuring words, and the nonverbal component, the avoidant body language, are completely at odds. And a client, especially one who is highly attuned to artificial behavior because of trauma, will immediately spot that dissonance.
Right. They ignore the polite words and just feel the fear radiating from the provider.
The words become totally meaningless. They know when you're just going through the motions. Which brings us to the tension between genuine interest and self-disclosure, because to build a real connection, you sometimes have to be honest about your own humanity.
You do. But in a clinical setting, honesty is highly regulated, isn't it?
Very. Sometimes honesty requires self-disclosure, but there are incredibly strict rules governing what a provider is allowed to share about themselves. You don't just dump your life story onto the patient to prove you're relatable.
Okay, I hear you logically, but practically, I have to push back on this a bit.
Go for it.
If we're talking about building a real human connection, isn't sharing our deep, vulnerable struggles exactly how humans normally bond? Like if a patient is sitting across from me, sobbing over a devastating divorce, and I've been through one too,
Yeah.
standing there in total stoicism feels like clinical abandonment.
It feels cold.
Right, it feels robotic. Why can't I just say, "I've been there. My divorce destroyed me too. I know how much this hurts"? Wouldn't that instant bonding be a powerful tool?
It's a very natural instinct, but you have to look at the direction of the emotional energy in the room. What you're describing is the mechanism of a social friendship.
Okay.
In a normal friendship, the relationship is a two-way street. I carry your burdens for a minute, you carry mine. But in a clinical setting, the focus must remain entirely 100% on the client.
So by sharing my trauma, I'm accidentally stealing the spotlight.
Worse than that, you're shifting a cognitive and emotional load onto the patient. If you start sharing raw, unhealed trauma like the intimate details of a recent divorce, you are subtly asking the client to comfort you.
Oh, wow.
Yeah. Or at the very least, you're forcing them to navigate your emotional landscape while they're already drowning in their own. You have completely flipped the caregiving dynamic. The client is there to heal, not to process the nurse's unresolved baggage.
That makes a lot of sense when you frame it as an energetic burden. The patient shouldn't have to worry about triggering the therapist.
Exactly. It's a massive safety red flag on exams, too. If an answer choice involves the nurse sharing deep personal trauma to relate to the patient, it is always the wrong answer.
But then, what is a provider allowed to share? How do you prove you're human without trauma dumping?
The rule of thumb is that self-disclosure should only involve resolved, everyday, non-value-laden frustrations. It has to be benign.
Like what?
For example, if a patient is talking about feeling overwhelmed by small things, a provider might share that they felt frustrated that morning because they got stuck in terrible traffic and spilled their coffee.
Just a microdose of humanity.
Exactly. These represent common day-to-day experiences. They show the provider lives in the real world and understands stress. But crucially, a spilled coffee doesn't burden the client. The client doesn't feel the need to offer deep emotional support over a traffic jam.
Right. The focus seamlessly returns to the client's far more severe struggles. That distinction between whose feelings are taking up the oxygen in the room is the perfect bridge to perhaps the most misunderstood concept in everyday life.
Empathy versus sympathy.
Yes. The massive difference between empathy and sympathy. We use these words interchangeably all the time, but structurally, they're opposites.
They are completely different mechanisms. Empathy is the ability to perceive the meanings and feelings of the client and communicate that understanding back to them without ever taking those feelings on as your own.
It's objective compassion.
Exactly. Let's use a grounded scenario that illustrates the friction between these two approaches. Imagine a client pacing the room, highly distressed, saying, "I'm so confused. My son just visited, and out of nowhere, he demanded to know where the safety deposit box key is."
Okay, so if the nurse is using empathy, their goal is to act as a clear mirror.
Right. They use techniques like reflection or clarification to help the client unpack the anxiety. The nurse might say, "You're feeling confused because your son asked for the safety deposit key," or "Are you confused about the underlying purpose of his visit today?"
Notice what the nurse didn't do there. They didn't offer an opinion on the son. They didn't tell the patient how to feel.
No, they just held up a mirror, reflecting the client's own words back to them, which invites the client to keep exploring the thought. It keeps the space open.
But what does sympathy look like in that exact same scenario?
Sympathy is feeling pity and inevitably projecting your own personal concerns into the space. A sympathetic nurse would hear about the son, feel a pang of personal recognition, and say, "Oh, I know exactly how confusing sons can be. My own son confuses me all the time. He never calls, and I know how awful that makes you feel."
You can physically feel the air get sucked out of the room for the patient.
Yep. The patient was just about to explore a very specific fear about their financial security, and suddenly the roadblock of the nurse's personal family drama is dropped right in the middle of the conversation.
The nurse hijacked the interaction.
Totally. Sympathy shifts the emphasis back to the provider's ego. It actively inhibits the client from exploring their own unique fear because now the social contract dictates that the client has to nod politely and acknowledge the nurse's sadness. Empathy leaves the space open, sympathy clutters it.
It's almost like sympathy is a trap disguised as kindness. It feels good to the provider. They feel like they're connecting, but it actively stunts the patient.
And that leads us to the next architectural pillar, acceptance and positive regard. This is the incredibly difficult practice of judging a behavior while unconditionally accepting the human performing it.
Because in psychiatric care, you're going to encounter behaviors that are socially unacceptable, aggressive, or deeply uncomfortable.
Oh, absolutely. But acceptance does not mean you tolerate abuse. It means you don't respond punitively to the person's core worth when they act out. You accept the person as intrinsically valuable while setting a steel boundary against the action.
Let's ground this in a real clinical interaction. Imagine a scenario where a client, who maybe struggles with impulsivity, inappropriately reaches out and puts their arm tightly around the nurse's waist during a session.
The instinctive social response, and an entirely unhelpful one, would be to punish them verbally and emotionally. The nurse might snap, "Stop that immediately. What has gotten into you? I'm leaving this room right now."
Which is purely punitive. It attacks the client's character, what's gotten into you, and it uses abandonment as a weapon.
It says, if you make a mistake, you lose your care. But the therapeutic alternative is a masterclass in emotional discipline. The nurse needs to physically remove the client's arm, maintaining safety, and say firmly in a neutral tone, "Do not place your arm on me. We are working on your relationship with your significant other, and that work does not require you to touch me." Now let's continue with what you were saying.
It's brilliant. Let's dissect why that works. First, the boundary was set clearly. Do not place your arm on me. No ambiguity.
None. But notice there is no anger, no shame, no character assassination. And the most important part is the pivot at the end. Let's continue.
That pivot is unconditional positive regard in action, isn't it?
Yes. By saying "let's continue," the provider sends a massive psychological signal. Your behavior was unacceptable and I stopped it. But you are still safe here. I am not abandoning you. Your core worth is intact.
It requires an unbelievable level of internal discipline to separate your own startle response from the clinical goal, which introduces a major realization. If the primary tool isn't a scalpel, but the nurse's own personality, then that tool has to be meticulously calibrated.
You cannot build these connections if your own psychological house is a mess. You can't navigate a client's mind without first mapping out the terrain of your own. The absolute bedrock of psychiatric care is relentless self-awareness.
Meaning you have to understand your own values, beliefs, and attitudes.
Because if they remain unconscious, they will control your clinical decisions. Let's start with values, because we all think we know what our values are, but it's often incredibly vague. To make it actionable, the framework outlines a specific method called the values clarification process.
But the three-step mechanism, right? Choosing, prizing, and acting.
Exactly. This forces you to figure out what abstract standards actually drive your day-to-day behavior. Let's use a non-clinical example. Imagine a college student who considers themselves generally neat and orderly. They get assigned a roommate who is chaotic, dirty clothes everywhere, half-eaten food on the desks.
A classic nightmare scenario.
Right. At first, the neat student probably doesn't intellectualize it. They just feel a knot of anxiety in their stomach every time they walk into the dorm. They avoid the room, they're reacting, not analyzing.
So if they apply the values clarification process, they move to step one, choosing.
Yes, they step back, examine the situation objectively, and realize they view the use of shared space fundamentally differently than their roommate. They look at all the options, living in chaos, fighting constantly, or seeking order, and they freely choose to value orderliness. They name it.
Then comes step 2, pricing.
They don't just quietly hold this value, they attach themselves to it. They might discuss it with friends or an RA. They publicly acknowledge, I am someone who needs a clean environment to function. They cherish the value.
And finally, step 3, acting. Because a value means nothing if it doesn't manifest in behavior.
Exactly. They put the value into action by deciding to sit down and negotiate a concrete compromise with the roommate. Now, why does this matter for a healthcare provider?
Because if a nurse doesn't know what they deeply value, like punctuality or self-reliance, they'll unconsciously punish clients who don't share those values.
Spot on. If you secretly value extreme self-reliance and you haven't clarified that to yourself, you're going to feel a subtle, unexamined contempt for a patient who exhibits high dependency. You'll think you're evaluating their clinical progress, but you're actually judging them against your hidden personal moral code.
And it extends beyond values into beliefs and attitudes, too.
Right. There's a critical difference between objective beliefs and irrational ones. Objective beliefs are backed by evidence. Irrational beliefs are often formed by a fear of the unknown or prejudice. And then there are attitudes, which operate as a frame of reference.
There's a great example of how attitude dictates reality. Imagine you're standing in a crowded grocery store line. You're in a rush. And the person at the very front of the line is slowly, meticulously counting out exact change in pennies and nickels.
A negative attitude views this as a personal affront. It's an infuriating waste of your time, and it ruins your mood for the next hour. Your physiological stress response spikes.
But a positive mental attitude reframes that exact same objective reality. Instead of a trap, it becomes a pause. You realize you can't change the person counting pennies, so you reframe the next 3 minutes as a chance to practice deep breathing or just rest your legs.
Now apply that to a clinical setting. If you approach every resistant patient with a negative attitude, assuming they're just being deliberately difficult, you'll approach them with hostility. You have to consciously reframe the experience. This resistance is a symptom of their fear, not attack on me.
But discovering these hidden biases isn't something you can just do alone in a dark room. We're exceptionally good at lying to ourselves.
We really are. To help providers map out these blind spots, psychology relies on a tool called the Johari Window.
The Johari Window. It's a grid divided into 4 quadrants, right?
Yes, and together they create a comprehensive portrait of a person's self-awareness. Let's walk through them, because this is highly testable material for nursing students and highly applicable to everyday life.
Okay, quadrant 1 is the open or public area.
These are qualities that you know about yourself and that everyone else knows about you too. The shared reality. For example, you know you're highly organized and your coworkers constantly rely on your spreadsheets. You both see it.
Then we move to quadrant 2, which is the blind or unaware area. This is the danger zone.
The absolute danger zone for a psychiatric professional. These are qualities known only to others, but you are completely blind to them.
Let's dive into a clinical example of this. Imagine a nurse who internally identifies as deeply compassionate and approachable. In her mind, she's the ultimate safe space for patients. But in reality, whenever she's concentrating hard on a chart or listening intently, she furrows her brow and violently scowls.
She has no idea she's doing it. But the patients see it. A patient suffering from severe depression looks up, sees this nurse scowling, and instantly internalizes it. She hates me. I am a burden. The patient shuts down and refuses to open up.
And the nurse is totally baffled. She thinks, why is this patient resisting my help? I'm so approachable. Her blind spot is actively destroying the intervention, and she's blaming the patient's pathology.
Exactly. Then you have quadrant 3, the hidden or private area. These are qualities known only to yourself. Things you deliberately hide, insecurities, private fears.
And finally, quadrant 4 is the unknown area. Qualities undiscovered by both you and everyone else, like deep latent potentials or repressed traumas.
Right. And the ultimate goal for any provider is to expand quadrant 1, the open area. You want to move as many qualities as possible out of the blind, hidden, and unknown quadrants into the light.
And how do you do that?
The only reliable mechanism is seeking honest, unfiltered feedback from your colleagues. You have to create an environment where a coworker can pull that nurse aside and say, hey, I know you care deeply, but when you listen, you look incredibly angry.
So high insight isn't a bonus trait. It's a non-negotiable requirement for safety.
Because if you have massive blind spots, your preconceptions will hijack the relationship before it even begins. Which brings us to a really fascinating framework by Barbara Carper called her Patterns of Knowing.
Hildegard Peplau, who's basically the architect of modern psychiatric nursing, warned constantly that provider preconceptions are massive roadblocks, right?
Yes, and Carper wanted to outline how nurses actually acquire knowledge to navigate around those roadblocks. Carper identified 4 distinct patterns of knowing: empirical, personal, ethical, and aesthetic.
Let's see them applied in a high-stakes clinical scenario. Let's imagine a client who is beginning to experience a severe panic attack in the common room.
Okay, let's look at the first pattern. Empirical knowing. This is the hard science, the textbook data. The nurse looks at the patient and empirically knows a panic attack involves the activation of the sympathetic nervous system. They know the pulse rate will spike above 120, respirations will become shallow, and the body will flood with cortisol.
It's the physiological map.
But the map isn't enough. Next, the nurse accesses personal knowing. This is knowledge derived from life experience and internal reflection. The nurse looks at the sheer terror on the client's face, and rather than just seeing symptom presentation, they feel a resonance. They've experienced panic or sat with enough terrified people to understand the subjective horror of it.
It allows for genuine empathy. Then a friction point arises, requiring ethical knowing. This is derived from moral knowledge and professional duty.
Right. Let's say it's the very end of the nurse's 12-hour shift. They're exhausted, their replacement is waiting, and they desperately want to go home. Empirical knowing says the patient's vitals aren't currently fatal, but ethical knowing dictates that abandoning this specific client in the middle of a crisis violates the core tenet of care.
The moral weight forces the nurse to stay.
And finally, we have the most elusive pattern: aesthetic knowing. This is the art of practice, the clinical intuition that develops over thousands of hours of observation.
How does one actually train aesthetic knowing? What does it feel like?
It feels like a shift in atmospheric pressure. Before the panic attack even fully manifested, the nurse utilizing aesthetic knowing sensed a change. They noticed a subtle jumpiness in the client's gait, a slight flattening of their vocal tone. They couldn't necessarily measure it on a heart monitor yet, but aesthetically they perceived the discord.
It's the synthesis of all the other types of knowing running in the background.
It really is. But here's where the entire framework gets flipped on its head. A 5th pattern was added years later by a theorist named Munhall, and she called it unknowing.
Unknowing. This is maybe the most profound philosophical concept we'll discuss today. It's the deliberate choice by the nurse to admit that they do not know the client's subjective world.
It's actively putting away all assumptions, all textbooks, and all past experiences.
I want to try an analogy here. If empirical knowing is memorizing the topographical map of a city, unknowing is the realization that the match is not the territory. You can know all the textbook definitions of major depressive disorder, but you have to walk the physical street with the client without assuming you already know where the potholes are.
That is a flawless analogy. When providers rely solely on the map, their empirical data, or their personal prejudices, they walk right past the reality of the patient. There's an example that perfectly illustrates this failure.
All right, the preconception example. Imagine a Hispanic male client who has grown up with a very rigid, stereotypical idea that nursing is exclusively women's work. Because of this cultural map he holds, he refuses to interact with the male nurse assigned to him.
Now look at the male nurse. He has his own flawed map. He harbors a preconceived notion that all Hispanic men are inherently macho and prone to violence. So when the client gruffly refuses his care, the male nurse doesn't explore the rejection. He's actually relieved. He thinks, great, I didn't want to deal with an aggressive guy anyway.
Both men looked at their maps and entirely refused to walk the actual territory.
The male nurse completely abandoned his clinical duty. He missed the opportunity to say, I notice you're uncomfortable with me being your nurse. Let's talk about what care means to you. Unknowing is the act of saying, teach me who you are.
So if we look at what we've built so far, we have calibrated the instrument. The provider is hyper-aware of their Johari window. They're practicing unknowing, utilizing objective empathy, and projecting absolute congruence. Now, how do they actually build the structure of the treatment?
We shift from the internal mindset to the external framework. And the very first step is pouring the concrete foundation: boundaries. The framework categorizes relationships into 3 distinct types: social, intimate, and therapeutic.
Let's start with social relationships. These are interactions for friendship, companionship, or getting a task done.
Right. The communication is fluid and superficial. You chat about the weather, sports, the weekend. Roles are constantly shifting. One day you give advice, the next day you're crying on their shoulder.
And the outcomes are rarely assessed. You don't sit down with your friend and say, all right, let's evaluate the therapeutic progress we made today against our quarterly goals.
Exactly. A tiny bit of socializing is acceptable in a clinical setting just to establish basic rapport. But if it fully devolves into a social relationship, the heavy lifting simply won't get done. Superficiality is comfortable, but it doesn't challenge the pathology.
Then you have intimate relationships, emotional commitment, mutual needs, intense vulnerability.
And the mandate here is unequivocal for nursing students to remember. The intimate relationship has absolutely no place in any professional caregiving interaction. Zero. The moment a dynamic shifts toward intimacy, it becomes profoundly destructive.
Which isolates us to the therapeutic relationship. This type differs fundamentally because the focus is entirely on the client's needs. It's a one-way street of care.
The provider uses all their skills, but their own personal needs for validation, gratitude, or friendship must be left at the door. If a provider finds themselves overly concerned about whether the client likes them, that's a massive red flag. Healing often requires the provider to be unpopular.
To structure this therapeutic relationship, modern psychiatry relies heavily on Hildegard Peplau. She developed a structural model divided into 3 interlocking phases: orientation, working, and termination.
This is the actual blueprint of treatment. Phase 1 is orientation. It begins the moment the provider and client meet and ends when the client successfully identifies the core problems they need to work on.
But the work actually begins before they even say hello, doesn't it?
It does. It requires heavy self-assessment. The provider reviews the chart and asks, does this client's history trigger anything in my own Johari window? If the incoming client has a history of severe aggression and the nurse grew up with a violent parent, the nurse has to mentally prepare for that specific trigger.
Once they do meet, the primary goal is establishing the contract. It outlines the rigid parameters, the time they will meet, the place, the length of the sessions, and the responsibilities of both parties. It creates a safe container.
And a non-negotiable part of building that container is establishing the absolute rules of confidentiality. The client needs to feel secure, but the provider must also clearly outline the limits to that secrecy.
Right. You can never promise total secrecy. If a client says, I'm going to jump off the parking garage tonight, but you have to promise you won't tell, the provider cannot hesitate. They have to say, I cannot keep that promise. Your physical safety will always override your privacy.
This is a huge exam topic. It's legally codified, stemming from a famous legal precedent from 1976, the Tarasoff versus Regents of the University of California decision. It established the duty to warn.
We have to dive into the backstory of Tarasoff. What actually happened in that case?
The tragedy unfolded at UC Berkeley. A graduate student named Prasenjit Padar was seeing a university psychologist. During his therapy sessions, Padar explicitly stated his intention to murder a young woman named Tatiana Tarasoff.
So the therapist hears a direct homicidal threat against a specific named target. What did they do?
The therapist actually took it seriously. He informed the campus police. The police detained Padar, interviewed him, concluded he seemed rational, and let him go. But here's the critical failure. Neither the police nor the therapist ever warned Tatiana Tarasoff or her family.
Because the therapist believed his duty of confidentiality prevented him from reaching out.
Exactly. And the tragic result happened. Padar murdered her. Her family sued, and the California Supreme Court ruled that while confidentiality is essential, the professional privilege of confidentiality ends where public peril begins.
The protective privilege ends where the public peril begins. That is powerful.
It legally mandated that mental health professionals have an affirmative duty to protect individuals being explicitly threatened. If a client makes a credible homicidal threat, the provider must break confidentiality, report it to supervisors and police, and make reasonable efforts to warn the intended victim.
So all of these heavy ground rules are established in the orientation phase. Once that trust is solidified, we transition into phase 2, the working phase.
The working phase is divided into problem identification and exploitation. And exploitation here just means to intensely explore and mine the problems for insight.
This is the messy, painful middle of therapy. And because digging up trauma is agonizing, clients frequently push back with testing behaviors.
Testing behaviors are fascinating, but difficult to endure. A client might act out aggressively, tell outrageous lies, or completely shut down and refuse to speak.
Why do they do that if they're there to get better?
It's an unconscious defense mechanism. When a client gets dangerously close to an uncomfortable core truth, say, realizing their substance abuse is driving away their kids, their anxiety spikes to an intolerable level.
Yeah.
To relieve that pressure, they test the boundaries. They try to distract the provider or see if the provider will abandon them, which would confirm their deepest fear. I am unfixable.
So how is the provider supposed to handle a patient screaming in their face without getting derailed?
The provider must stay anchored in the structure. Don't react to the emotional bait. The framework suggests a disarming response. The provider lowers their voice and says, "It seems as if we have hit a very uncomfortable spot for you today. Would you like to let this topic go for now and return to it later?"
Wow, let's look at why that works. First, it diffuses the fight. It refuses to match the patient's aggressive energy. Second, it objectively acknowledges the discomfort without judging it. And third, it offers the patient autonomy.
Would you like to let it go for now? It places the responsibility for healing back in the client's lap. The provider isn't there to give life advice. They act as a guide. If a depressed client constantly complains their family doesn't care, the provider doesn't say, "You should call your mom."
Yeah.
The provider explores how the client communicates until the client organically realizes, "Oh, I only reach out to criticize them."
But navigating the working phase involves crossing a field full of psychological landmines: transference and countertransference. Let's define transference first.
Transference occurs when the client unconsciously takes intense feelings they have about a significant figure from their past, like a deeply critical parent, and transfers those exact feelings onto the healthcare provider. Because the provider is an authority figure, the client's brain overlays the ghost of their past onto the nurse.
So they might display intense resistance or clinging dependency that's completely out of proportion to anything the nurse has actually done.
Exactly. And countertransference is the mirror image. It is when the provider projects their own personal unmet needs or unresolved childhood conflicts onto the client.
Like the nurse who grew up as the youngest, ignored child in a large family.
Right. If this nurse gets a patient who is dismissive and won't listen, instead of viewing this objectively as a symptom, the nurse experiences countertransference. They unconsciously react with intense, punitive anger. They are mad at the patient. They are mad at their older siblings from 20 years ago.
This is exactly why that rigorous self-awareness from phase 1 is so vital. If you don't scan your own hotspots, you'll respond from old wounds rather than professional objectivity.
Now, once the heavy lifting is done and the client has practiced healthier coping skills, the relationship moves to phase 3, termination. This begins when the agreed-upon problems are resolved, and it concludes with the definitive end of the therapeutic relationship.
Okay, I have to push back on this because it sounds unbelievably harsh. It sounds like a forced breakup. If the relationship is working and the provider is helping the client stay stable, why force a termination? Why can't the patient just see the provider indefinitely for maintenance?
It's a natural, empathetic reaction to want to maintain the connection, but it touches on the core philosophy of therapeutic care. If therapy continues indefinitely when the acute problems are solved, it shifts from healing to fostering dependency. The ultimate goal of the therapeutic relationship is to make itself completely obsolete.
To make itself obsolete.
Yeah.
You're working to put yourself out of a job.
Yes. The final cure is proving to the client that they can stand alone, that they have internalized the tools and no longer need the external crutch of the provider. If a provider allows the relationship to continue simply because it feels warm and comfortable, that is a profound failure of the therapeutic model.
Because it means the provider is meeting their own ego need to feel needed, rather than fostering the client's independence.
Exactly. And because it feels like a profound loss, clients will often panic as the termination phase approaches. They'll try to stall. A stable client might suddenly regress, act agitated, or bring up already resolved traumas just to justify keeping the provider engaged.
They're trying to prove they're still broken so you won't leave them.
It is heartbreaking. But the provider has to gently refuse to take the bait. They acknowledge the grief of saying goodbye, but relentlessly refocus the client on their demonstrated growth and readiness to face the world alone.
So we have built this robust architecture: orientation, working, termination. But any building can collapse if the structural integrity isn't maintained. We need to explore the danger zones.
And the most insidious thing about these danger zones is they almost never start with malice. The breakdown of inappropriate boundaries almost always begins entirely unintentionally, paved with the best of intentions.
Right. It starts with a tiny slip. Sharing just a little too much personal information, thinking it will help the client feel less isolated. But once that boundary is crossed, the dynamic has fundamentally shifted.
Accepting gifts is another massive breach. A patient knits you a scarf, it feels cool to reject it. Or giving out a personal phone number because you're worried about a patient over the weekend. It seems like profound kindness, but it immediately moves the relationship from therapeutic to social or intimate. The framework shatters.
Then there's the trap of sympathy and dependency. When empathy degrades into sympathy, the provider feels so overwhelmingly sorry for the client that they try to compensate by overdoing things for them.
And clients are adept at recognizing this. If they realize the provider will do the hard work for them, the client will regress. They'll refuse to practice coping skills unless that specific sympathetic provider is present to coax them through it.
It's exactly like muscle atrophy. By doing the work for the client, the sympathetic provider is actively stunting their psychological growth.
Conversely, you have the danger of non-acceptance and avoidance. Providers are human. Sometimes you'll be assigned a client whose behavior is deeply distasteful to you. Maybe they have a history of a heinous crime. If the provider cannot practice unknowing and allows disgust to show through micro-expressions or avoidance, the relationship is dead on arrival.
What is a provider supposed to do then? You can't magically turn off your disgust.
You must immediately confront these prejudices in clinical supervision. Work through your Johari window. But if you absolutely cannot resolve those punitive feelings, professional ethics demand you request a different assignment. It's better to step away than to subject a vulnerable client to subtle, continuous rejection.
But perhaps the most pervasive danger zone is compassion fatigue, a specific type of secondary traumatic stress where the provider absorbs so much of the burden that they lose the ability to compartmentalize.
It's a physiological and psychological breakdown. The provider's time outside the clinic becomes consumed by obsessive worries about clients. They stop socializing, stop sleeping, and their identity becomes consumed by being a savior.
This is the massive irony. Culturally, we celebrate this. We call them healthcare heroes. We applaud the nurse who sacrifices their marriage and sleep to stay at the hospital. We view caring too much as a virtue. But this framework explicitly states that this is incredibly dangerous. Sacrificing your personal life turns you into a massive clinical liability.
Because a burned-out provider is highly prone to severe boundary violations, their emotional reserves are empty, so they unconsciously start looking to their vulnerable clients to fill their emotional cup. They start needing the client's gratitude. Failing to take care of oneself means failing the client. You cannot pour healing from an empty psyche.
And when the psyche is empty, abuse happens. The framework lists very specific warning signs that a relationship has slipped into an abusive dynamic.
These are red flags requiring immediate intervention. Things like keeping secrets with the client that aren't shared with the care team. A sudden increase in communication outside clinical hours.
Making special exceptions for one specific client. Trading goods. Extended closed-door sessions with no justified clinical outcome. Or becoming highly defensive when other staff question your care plan.
These are all blaring alarm bells that the walls have collapsed. It requires constant vigilance. Which brings us to the final layer. Within these strict boundaries, the provider has to fluidly shift between different functional roles depending on what the client needs in that micro moment.
The many hats of healing. 4 primary roles. The first is the teacher.
During the working phase, the provider is actively instructing, teaching coping methods, explaining medications, and the critical element here is absolute honesty regarding your own limitations.
Right, eagerly admitting when you don't know something, saying, I actually do not know the answer to how that medication interacts with your diet, but I'm going to find out right now.
Yeah.
That builds infinitely more trust than trying to bluff your way through.
The second role is the caregiver, providing literal physical care alongside emotional support. But in a psychiatric setting, physical care requires intense verbal communication.
Because touch is complicated.
Yes. If a client needs physical assistance, the provider must explicitly explain exactly what they are going to do before making physical contact. Many clients have severe trauma histories. If you reach out without warning, they might confuse caregiving touch with a threat. You have to receive consent constantly.
The third role is the advocate, acting as the shield for the client when they cannot advocate for themselves, ensuring their privacy and rights against a massive medical system.
Like stopping a senior physician who walks into a patient's room and starts a physical exam without closing the door. The nurse acting as advocate must physically step in, drape the patient, and close the curtain, even if it angers a superior.
But the advocate role in psychiatric care introduces a deeply complex ethical dilemma, the paternalism debate.
It does. In traditional medicine, advocating usually means supporting the patient's right to choose. But in psychiatric care, If a client is actively severely suicidal and demanding to leave the hospital, advocating for their ultimate safety means involuntary hospitalization, locking the doors against their will.
How does a provider reconcile this? You're taught to be the champion for patient autonomy. But the moment they're in the deepest crisis, you have to overrule their voice. How do you maintain trust when you're essentially acting as their jailer?
It is undeniably the heaviest burden in mental health care. Critics call it paternalism stripping marginalized people of human rights. But the clinical framework forces a different perspective. Physical safety is the ultimate non-negotiable prerequisite for any future autonomy.
You can't make choices if you aren't alive.
Exactly. Intervening to save their life, even when it violates their current illness-driven wishes, is viewed as the most profound form of advocacy possible. You are legally and ethically holding their life in trust.
You are advocating for the healthy, future version of the patient who isn't currently in the room to speak for themselves.
That is exactly right. You hold the line until they are well enough to hold it themselves, which transitions to the final, most delicate role, the parent surrogate.
When clients are in severe distress, they often regress to childlike behaviors. They might throw tantrums or demand to be coddled. And it is terrifyingly easy for a provider to accidentally adopt an authoritative, strict parent tone.
You fall right into a literal parent-child dynamic. But if you start acting like a scolding parent, the client will respond by acting like a rebellious child. All therapeutic momentum ceases. You're just recreating their childhood trauma.
So how do you avoid the trap when the patient is literally acting like a toddler?
The provider must firmly reiterate boundaries, but relentlessly maintain an adult-to-adult communication style. You provide a nurturing environment, but you absolutely do not parent. You speak to the adult inside their aggression until the adult comes back to the surface.
So let's take a massive step back and look at the architectural blueprint we just mapped out.
We dismantled the myth of just being nice. We looked at the rigid building blocks, congruence, objective empathy versus suffocating sympathy. We explored the internal calibration required, clarifying values, facing the Johari Window blind spots, and Carper's patterns of knowing.
Then we watched the architecture get built. Peplaw's phases, the rigid orientation contract, Tarasov duty to warn, the messy emotional lifting of the working phase, and the painful separation required in the termination phase.
We mapped the danger zones, how good intentions slip into boundary violations, how sympathy breeds dependency, and how the healthcare hero myth leads to compassion fatigue.
And finally, the dynamic acts. The honest teacher, cautious caregiver, fierce advocate, and grounded parent surrogate. It is a masterful, exhausting blueprint for human healing.
It forces us to realize that the provider's own humanity, when strictly bound by rigorous professional discipline, is the actual medicine.
Which brings me to a final thought for today. We talked about Munhall's concept of unknowing, actively admitting you don't know the client's subjective world, forcing you to put your map in your pocket and truly listen.
The key to authentic connection.
But what if we didn't just leave it locked up in the clinic? Think about the people in your own life right now. We build up these dense preconceptions about the people we see every day. We think we have their map entirely figured out. We know exactly how our partner's going to react. We know exactly what our teenager is thinking. But what if tomorrow morning you practiced unknowing with your spouse or your colleagues? What if you actively chose to forget your assumptions, put away your historical map, and approach them as if you were learning about their inner world for the very first time? It's a clinical tool, sure, but it might just be the secret to saving our everyday relationships too.